Hi, my name is Erin Weber, and today I'm going to teach you about cyanotic congenital heart diseases, or the 5 T's: tetralogy of Fallot, transposition of the great arteries, tricuspid atresia, truncus arteriosus, and total anomalous pulmonary venous return. So besides a mouthful, what are cyanotic congenital heart diseases? From the word congenital, we know that this is a condition that is present at birth and develops while we are in utero. Our textbook states that there are 2 pathologies, obstructions and shunts. Shunts refer to abnormal pathways of circulation in the heart and are characterized as right to left or left to right. Today I'm going to focus on right to left shunts, which are also known as cyanotic defects. The cyanosis is a result of unoxygenated blood from the right side of the heart mixing with blood in the left side of the heart, via pathways I will soon discuss, and entering our peripheral or systemic circulation before passing through the lungs. Congenital heart defects, or CHDs for short, can be devastating. According to the CDC, they are the most common birth defect with a rate of 1%, or about 40,000 births per year in the U.S. Critical defects occur in about 25% of cases, and these infants may require immediate as well as subsequent surgeries in their first year of life. The pathology of heart defects is not well understood, but our textbook notes that there is a 2 to 10-fold increase in siblings, and more males are affected than females. A maternal infection with rubella has also been associated with CHD development. Although not well understood, they are thought to be multifactorial with genetic and environmental components. According to the CDC, hospital costs for individuals with CHDs amounted to about $1.4 billion in 2004, which they estimate is equivalent to $1.9 billion in 2011 dollars. In order to understand how defects manifest, I think we first need to look at normal fetal heart development. I will summarize the process as discussed in our textbook by Kopstead and Banasic, which starts on page 400. The primitive heart begins as an enlarged tube, with 3 different layers that differentiate into the various heart tissues, such as the septa, valves, and muscle. At day 23, our heart tube begins to beat and folds in on itself to form a loop. The loop begins to form the primitive features of the atria and the ventricles, as well as the truncus arteriosus, which is the outflow pathway. In this image, we can easily visualize the difference in the circulatory path of blood in the fetal heart versus the newborn heart. When the fetal heart is mature, 2 key pathways allow for blood to bypass the collapsed fetal lungs. The foramen ovale, which is a hole or passage between the atria, and the ductus arteriosus, which is a channel connecting the pulmonary artery and the aorta. The high vascular resistance of our collapsed lungs allows for the pressure gradient necessary for fetal blood flow. When we take our first breath as we are birthed into the world, our lungs inflate, the resistance dissipates, and these pathways generally close. Let's take a look at this brief animation from the Children's Hospital of Philadelphia to get a better understanding.
As soon as the cord is clamped, the ductus venosus ceases to carry blood to the heart, and it begins to constrict within the first few hours or days of life. The very first thing that happens when the fetus is born is it takes its first breath, the lungs expand, and so the resistance or pressure in the lungs drop, and that promotes blood flow into the lung itself. The ductus arteriosus begins to constrict and is typically fully closed within 24 to 48 hours of life, and blood is now then fully directed into the lung. As the blood returns to the left side of the heart after traversing the pulmonary circulation and picking up oxygen, pressure in the left atrium rises just a bit, And the trapdoor of the foramen ovale, which was open before birth, now begins to close, usually within the first few days of life.
Now that we have a better understanding of normal heart and circulatory development, let's delve into the cyanotic defects, or 5 T's. For each defect, I will cover the pathophysiology, diagnosis, and treatment. I will later discuss the signs and symptoms collectively as they are similar. Tetralogy of Fallot is the most common heart defect and is named after Dr. Etienne Fallot, who in 1888 recognized the 4 characteristic abnormalities. The first, the ventricular septal defect, or VSD, allows for mixing of blood between the 2 ventricles. Second, an overriding aorta means the aorta is located between the 2 ventricles and over the VSD, allowing for oxygen-poor blood to enter peripheral circulation. Third, pulmonary stenosis, or narrowing of the pulmonary artery, inhibits adequate circulation of blood to the lungs. Fourth, right ventricular hypertrophy arises because of the increased workload caused by pulmonary stenosis. Thus, the cyanosis that occurs is a result of the mixed blood that is pumped into systemic circulation by the overriding aorta. According to the Baylor Scott and White Health System, tetralogy of Fallot is generally discovered within the first year of life. Auscultation of a heart murmur should lead healthcare providers to order diagnostic testing, which may include an echocardiogram, stress test, and/or nuclear heart scan. Treatment requires open heart surgery to close the VSD and widen the pulmonary artery. Here you can see that they've closed the VSD with a patch and then widened the pulmonary artery with a patch here as well. Transposition of the great arteries means that the aorta now arises from the right ventricle, and the pulmonary artery arises from the left ventricle, which results in 2 isolated pathways of circulation. As you can see in this diagram, the blood returning from systemic circulation stays on the right side of the heart and exits via the aorta. This blood bypasses the lungs and never receives oxygen. The CDC considers this defect a critical CHD. Diagnosis is typically made in utero, or within the first few hours to weeks of life. Echocardiograms are not standard prenatal care and are only performed if there is high suspicion for a CHD. Corrective surgery, called an arterial switch, involves excision of the great vessels and then suturing to their appropriate ventricles, as well as some rewiring of the coronary arteries. A temporary treatment may include a cardiac catheterization and a balloon atrial septostomy, or a balloon that maintains the atrial septal defect to allow mixing of blood until definitive treatment. Tricuspid atresia means the tricuspid valve has not fully developed. You also see atrial and ventricular septal defects. Blood bypasses the right ventricle, leading to underdevelopment. Diagnostics may include an electrocardiogram, chest x-ray, electrocardiogram or ECG, and cardiac catheterization. The Children's Hospital of Philadelphia outlines the treatment standards, noting that 2, possible 3 open heart surgeries are required. Prostaglandin, a potent local vasodilator, may be indicated prior to surgery. Closure of the patent ductus arteriosus at birth can induce severe cyanosis and compound circulatory issues for these babies. prostaglandin can reopen the ductus arteriosus until surgery. Next, we'll look at truncus arteriosus. As defined by Schumacher in the National Library of Medicine and the National Institute of Health, or NIH, in truncus arteriosus, the aorta and the pulmonary artery are fused, and a hole between the ventricles, or VSD, remains. The high level of mixing of blood results in systemic cyanosis. The CDC considers this another critical CHD, which requires almost immediate surgery after birth. Here you can see the normal circulation in the heart, blood going from the right atrium to the right ventricle and out to the lungs, and then coming back through the left atrium, the left ventricle, and then out through the aorta. In truncus arteriosus, here you can see that the aorta and the pulmonary artery are fused, and the mixed blood can enter circulation. As a provider, upon auscultation of the heart and lungs, you might hear crackles from fluid overload in the lungs, irregular heartbeats, and/or a murmur from the turbulent flow. An echocardiogram and X-ray can help make a definitive diagnosis. Treatment includes medications before surgery, including diuretics and inotropics like furosemide and dopamine. According to the Mayo Clinic, surgical repair within the first 2 months of life is associated with good outcomes. Total anomalous pulmonary venous return, or TA-PVR, is a condition in which the pulmonary veins do not connect with the left atrium. The CDC also considers this to be a critical CHD. I apologize that this picture is flipped and has the affected heart on the left, but you can see in the normal heart that oxygenated blood from the pulmonary veins enters into the left atrium, into the left ventricle, and then on into peripheral circulation. In TA-PVR, the pulmonary veins do not connect to the left atrium here. Instead, the blood circumvents the left side of the heart and mixes back with the unoxygenated blood. Newborns with TA-PVR are profoundly cyanotic and in severe congestive heart failure. If we are circumventing a majority of the left side of the heart, in particular the left ventricle, then there is going to be a tremendous amount of fluid overload in the lungs. Treatment for TA-PVR requires early surgical repair. The CDC reports that individuals that do survive often have lifelong complications. The signs and symptoms or clinical presentation of cyanotic CHDs are similar. What varies is the time to emergence from the time of birth, which is based on the type of defect and severity. These babies will have abnormal breathing patterns and difficulties due to altered circulation and perfusion. Their skin will appear bluish or cyanotic, hence the name, cyanotic congenital heart defects, which can be centrally and/or systemically. They exhibit poor feeding and lethargy and tend to have a weak pulse. Early diagnosis is imperative for newborn survival and quality of life. A cyanotic neonate needs an echocardiogram to distinguish between the various types of right to left shunts that we have discussed. Up to Date provides a wonderful table of possible other causes of central cyanosis. Differential diagnoses include airway diseases like pneumonia, aspiration, diaphragmatic hernias, and transient tachypnea of the newborn, or extrinsic factors like pneumothorax, pleural effusion, and thoracic dystrophy that result in a ventilation-perfusion mismatch. This means a mismatch between air moving through the lungs and oxygen in systemic circulation reaching the tissues. Alveolar hypoventilation can result from central nervous system depression in asphyxia, maternal sedation, seizures, neuromuscular diseases like neonatal myasthenia gravis, and airway obstruction. Cyanosis can also result from hemoglobinopathies like methemoglobinemia, either congenital or secondary to toxic exposure. Methemoglobin is a form of hemoglobin that contains ferric iron as opposed to ferrous iron, which has a decreased ability to bind oxygen. Maternal treatment for pneumocystitis carinii, pneumonia, or PCP and HIV with dapsone, as well as topical anesthetics that are commonly found in cocaine, meth, and heroin, can result in methemoglobinemia in the neonate. Finally, a diffusion impairment like pulmonary fibrosis or pulmonary edema from left-sided obstructive cardiac disease or cardiomyopathy must also be excluded. More often, CHDs are diagnosed at time of birth and not in utero. However, a fetal echocardiogram is possible. As I previously discussed, diagnostics may include an ultrasound, echocardiogram or ultrasound of the heart, a history of the mother and infant, clinical presentation, chest X-ray, and hyperoxia test. Most of the diagnostics I touched on previously. However, I want to briefly touch on the hyperoxia test. The NIH reports that although rarely necessary, because of the increased availability of echocardiography, this test can be used to differentiate between pulmonary and cardiac disease. In cyanotic CHDs, delivery of 100% oxygen will result in little to no change in the PaO2, or partial pressure of oxygen in the arteries, secondary to the circulatory defects. In his publication on UpToDate, Dr. Gegel reports that in cyanotic CHDs, the partial pressure of arterial oxygen does not go above 150 milligrams of mercury, whereas in pulmonary disease, it will exceed this. Timely treatment is crucial for CHDs and is type and severity dependent. As I discussed with each cyanotic defect, options include surgical repair and intervention, cardiac catheterization with stent placement, medications prior and post-surgery, and often lifelong specialized care with a cardiologist. Because the etiology of CHDs is not well understood, it is difficult to make clear recommendations for prevention. From the maternal standpoint, the American Academy of Pediatrics makes 7 recommendations: avoiding alcohol consumption, taking a multivitamin with folic acid, maintaining a healthy weight and diet, screening for chronic illness such as diabetes and high blood pressure, smoking cessation, medication screening, avoiding ill contacts, and avoiding exposure to heavy metals, herbicides, and pesticides. Children living with CHDs should have a cardiologist and maintain routine appointments, as well as be diligent about prescribed medications. Cyanotic CHDs can be critical and fatal, but timely recognition, accurate diagnosis, and early intervention can result in positive outcomes, and patients can live long into adulthood. This concludes my presentation. I hope you have a better understanding of cyanotic congenital heart defects, and I look forward to your questions.